This is Radio Health Journal. I'm Reed Pence. This week, how we experience pain.
It's a very lonely experience to be in pain because you can't really communicate particularly effectively what it is you're feeling.
Managing and enduring physical suffering when Radio Health Journal returns.
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
The technology is simple in a lot of ways, and we already have these issues. What's going to happen as it becomes more powerful and more complex? We have to start thinking about this now.
The field of artificial intelligence and its modern applications. Then,
I was sitting there at the end of my 30s and being like, did I do this wrong? I'm happy, but am I alone?
The woes of sticking to the traditional timelines of adulthood. I'm Marty Peterson.
and I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
No one wants to feel pain. However, we wouldn't get very far in life without it. Pain lets us know when we've been injured or contracted an illness. It drives us to seek medical attention before it's too late. Fortunately, most people do feel pain. Even primitive one-cell amoebas withdraw from harmful stimuli. But the sensation of pain can't be measured by any technology because it's only a perception in our brains, a perception that varies from person to person. And that makes pain management one of the greatest challenges healthcare providers face.
I often say to people, it's a bit like love. You know, when my wife leaves in the morning, she says, I love you. And occasionally I'll go, well, can you please unpack that and tell me what it actually means? Because we say I'm in pain or we say I love you, but those are experiences that mean different things to so many different people in so many different ways, expressed in, you know, a multitude of different contexts and situations, and really is quite unique to the individual. It's a very, sometimes I say it's a very lonely experience to be in pain because you can't really communicate particularly effectively what it is you're feeling.
That's Dr. Abdul Lalkin, a consultant in anesthesia and pain medicine at Salford Royal NHS Foundation Trust in Manchester, England. He's also author of the book An Anatomy of Pain, How the Body and Mind Experience and Endure Physical Suffering. Lalkin says the subjective nature of pain poses a problem for doctors, particularly when a patient applies for disability coverage.
I've just been reading a case where, you know, the psychiatrist and another pain physician and some orthopedic surgeons have gone, well, you know, this man's behavior is very disproportionate to the injury that he sustained. And I've said, but, you know, you can't feel what he feels. And when he comes to see you, because you've all told him, though, there's not much wrong with you, we can't see anything on our scans, he's trying to communicate to you in a very unconscious way what he feels. And that comes out as groaning, and he's struggling to come up from a straightened position. And yet what you're saying to him is that, well, we'll decide how much pain you're feeling and how much disability you should be experiencing. And I think we all make those judgments. And yet, when you review what we understand about the biological alarm system, which is pain, you realize that actually people do not present in the same way for a given injury.
The human understanding of pain has evolved throughout history. Pain that had no apparent cause mystified early cave dwellers. They understood that an arrow piercing the skin caused suffering, but they believed that demons inside the body caused sore backs or headaches that only a witch doctor or a shaman could exorcise.
Modern neuroscience understands and examines pain at a molecular level, at a genetic level. We look at the expression of receptors and, you know, functional imaging in the brain, tries to understand which brain pathways are involved. And then increasingly, we understand hormones and the immune system play a role in the activation of pain. And so We've gone all the way from, making holes in people's skulls to letting demons out to functional magnetic resonance imaging. The interesting problem, however, is that we're still using the drugs that we used 5,000 years ago to try and manage pain, because despite our sophistication in terms of our understanding of the pathophysiology of pain, it hasn't unfortunately led to specific treatments.
So doctors sometimes have to work around pain as they treat infectious diseases, kill cancers, and stabilize trauma.
And pain accompanies all of those conditions because you have damage. And where you have damage, nerves are stimulated to send messages to the brain, and people experience pain. And we help people sublimate their distress during the time of the acute pain. And we can block the sensations with local anesthetics. We can make them less distressed with opiates. We can reduce inflammation with anti-inflammatories until the body heals itself and the inflammatory chemicals that are stimulating those nerves settle down, and gradually the pain alarm system switches off. So we're not bad at doing that.
When pain persists, however, healthcare providers struggle to provide sufficient relief.
We struggle with arthritis, chronic back pain, fibromyalgia, neuropathic pain where nerves have been damaged either due to a disease process like diabetes or a prolapsed intervertebral disc that compresses your sciatic nerve, where the injury changes the way that nervous system functions. We're a bit at sea, really.
For example, with osteoarthritis, doctors may not treat pain itself, but rather replace the joints.
But even when you replace the joint in a technically perfect way, the pain may not subside because the pain is much more complex than just the structure of that joint. And in those situations where people have pain for a long time, and you're talking more than 3 to 6 months, and it starts to have a significant impact on the way they function, that's where we struggle. And many of the treatments we have actually end up doing more harm than good when they're given for a prolonged period of time. And the opioids are a situation where that occurs.
Today, many doctors have a substitute for that, prescribing medical marijuana instead of opioids. But Lalkin foresees a potential danger in that, too.
I'm not saying that cannabis plant or some of the cannabinoids within that plant don't have utility in the management of pain. But my view is that you need to be able to quantify how much drug in which patient, for how long, and at what cost. And I think if you don't have a robust examination scientifically of drug effect and drug harm and side effect, then you're just going to end up with the same issue with cannabis as you have with opioids.
But what if we could modulate our perception of pain without using powerful drugs? It's possible. Lalkin encourages patients to practice mindfulness training and change their expectations of pain relief to cope with chronic pain.
Damage is damage, but pain is optional. And when I say optional, I mean that you can modulate the experience. Like, look at the average NFL team, over 60 minutes, and you look at how offensive linemen crash into one another. And if you or I did that, we'd be carried off and stretched off. But they're conditioned to that. And those impacts are probably the equivalent of a car crash. And they must feel, and you are damaging soft tissue. But for them, there's context because it's their job and they've been doing it for years. And so when that damage, that soft tissue damage sensation gets to their brains, they walk it off.
Lalkin says an opposite scenario may also occur. An average citizen might manage pain fairly well that could be excruciating to an athlete. It's all a matter of context.
Say, for example, you're walking in your garden on a Saturday afternoon and you step into a nail, but you don't really have anywhere to be and, of an inconvenience. And you're a fairly resilient person. You might, go down to your local emergency department and get a tetanus shot and a plaster. But can you imagine how different that pain would be if you were about to run the 100 meters in the Olympics, having trained for 4 years? So that same physical damage yields a very different level of pain and a different level of pain-related distress.
There are other ways to relieve at least some of our pain without drugs, and we rely on them unconsciously every day. Have you ever wondered why rubbing a bumped knee works, or kissing a child's boo-boo?
The rubbing does a couple of things. It stimulates different sensations, which kind of compete at the level of the spinal cord for the unpleasant sensations going to your brain. And so the pain feels less. And we also started to realize that if you comfort somebody, the brain activates pathways that can block pain going to the brain. So if you watch a baby, babies will kind of bump their heads. And if you then look at them, they'll then start crying because your look of concern kind of cues them to realize, actually, this is not normal. The mother then goes over to her baby and kisses the child's forehead. And what that comforting does is it activates descending brain pathways, which modulates pain.
Recent experiments show that thinking of something comforting or pleasant also reduces painful sensations.
There's a study that always amuses me about medical students who are asked to imagine their best selves, in the future, $1 million earning Rodeo Drive plastic surgeons, and whilst they have their hand in a bucket of ice water. And those individuals who are thinking about an optimistic future are more likely to be able to tolerate the unpleasant sensation for longer than those who are perhaps thinking of a less optimistic or pleasant future.
However, all the visualizing in the world can't always take away all our pain, and Lalkin doesn't like to second-guess his patients about it. He accepts that pain is whatever the patient says it is.
You have to believe and understand and empathize with people and try as best to explain what's happening to them in an empathic and kind fashion. But if you normalize what they're going to feel and you support them and you encourage them, and you've also, prior to the surgery, addressed any of their concerns and expectations, then you can have a much smoother post-operative course. And so the overall conclusions that I've come to as a doctor is that if you can be anything, be kind and be compassionate and be clear, giving people unambiguous messages based on clear science and an honest understanding of the strengths and limitations of your craft.
And just as some doctors might say to a patient, your pain can't be all that bad, Lalkin says family members, too, can sometimes be guilty of a poor bedside manner.
When your husband and your son complain bitterly about what they're experiencing, that bitter complaint is often as a consequence of perhaps anxiety about what's happening to them. Generally, and I'm generalizing here now, women are better at expressing how they're feeling and integrating information, whereas men are often quite impatient. They want things solved immediately. They don't like being unwell. It's the difference between man flu. When a man has influenza or viral infection, he takes to his bed and, the world has to rally around him, whereas a woman continues to do all the things that she needs to do, including looking after her influenza-disabled husband or son. So it's the difference between illness and disease.
Kindness notwithstanding, Lalkin cautions that we're facing an epidemic of muscular and skeletal dysfunction due to obesity and sedentary lifestyles.
And I think people focus on their heart health and their lung health, but nobody really emphasizes the health of your bones, ligaments, and muscles, which ultimately is the machine that carries your brain around. And I think given the way we currently live, particularly in the Western world, we face increasing amounts of musculoskeletal related pain and disability in the future, unless we really change how we eat and live and exercise and, our pursuit for more and, lack of potentially mindfulness and focus on the here and now. I think that I've seen in my clinic does take its toll on people, particularly when they're older.
As much as we try to eliminate pain from our lives, it's necessary for our survival as a signal to our brains that something's wrong and needs attention. But how we endure and live with our pain is our choice. So the next time you undergo a painful procedure, it wouldn't hurt to keep in mind a pleasant experience, and it might just help you forget about the pain. Dr. Abdul Lalkin's book, An Anatomy of Pain, is available now. You can learn about all of our guests by visiting our website at radiohealthjournal.org. Our writer-producer this week is Polly Hansen. I'm Reed Pence.
Two nationwide surveys find that discrimination is a significant barrier to care for people with Alzheimer's and dementia. Half or more of non-white Alzheimer's caregivers report they face discrimination in navigating health care for the recipient. Dr. Carl V. Hill is Chief Diversity, Equity, and Inclusion Officer of the Alzheimer's Association.
The data suggests we have a long way to go to address lack of health equity in healthcare. More than 80% of non-white racial and ethnic groups say it's important for Alzheimer's care providers to understand their backgrounds and experiences. But fewer than half of Blacks and only about 60% of Hispanics and Asian Americans feel confident about their access to culturally competent providers.
The surveys also reveal a lack of trust among Blacks in research clinical trials, and half doubt that advances in Alzheimer's treatments would be shared. These findings are part of the 2021 Alzheimer's Association Facts and Figures Report. Find out more at alz.org/facts.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Twitter, Facebook, and Instagram to learn more, and check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.
Coming up next week on Radio Health Journal.
It's very easy to numb out with substances, and it's very easy to isolate because we are asked to isolate. We're choosing to isolate for another safety reason.
Assessing the psychological wreckage of the pandemic.
Then, the pandemic has boosted technology in the classroom, but is handwriting being left behind?
Anytime you use a different tool, it naturally is going to change the way you think. It's going to affect the way you process information.
All that and more on Radio Health Journal.